Okay, so dear participants, it's great honor for me to give lecture here. And thank you, Professor Gamaro Serroro and the organizing committee. The title of my talk is Emerging Challenges in Understanding and Treating Adenomyosis. So this is age distribution of patients with adenomyosis. The peak is over 40, but a certain number of patients are below 40, which are ages of human seeking pregnancy these days. Adenomyosis is diagnosed in 22% in infertile women less than 44 years, and they are undergoing ART. In other words, we treat many women with adenomyosis who will be pregnant in the future. So as for symptoms, pain symptoms, bleeding symptoms, and pressure symptoms by enlarged uterus are well known. And in addition, as shown in this meta-analysis, adenomyosis decreases clinical pregnancy rates here and increases the likelihood of miscarriage in clinical pregnancies obtained at IVF-ICSI. So what's more, recent studies indicated that adenomyosis increases the risk of preterm birth, as shown here. So the risk of preeclampsia here, and that of small for gestational age here, increase with the presence of adenomyosis. So then, how can we diagnose adenomyosis non-invasively? We have imaging modalities, ultrasound and MRI. Here is image features for the diagnosis of adenomyosis by ultrasound and MRI. In general, ultrasound diagnosis heavily depends on the skill of examiner. So I use ultrasound for screening, and I use MRI to see the details. So I'd like to summarize the backdrops of adenomyosis management. As I told, these days, there's often years of interval between onset of adenomyosis and attempting pregnancy. And we can make early diagnosis by ultrasound and MRI. Then, how can we give pain relief and prevention of reproductive problems to those patients? Medical treatment or surgical treatment. Basically, surgical treatment is in a second line and seldom chosen. So I talk about medical treatment today. This slide shows treatments for adenomyosis. For medical therapies, we have these drugs, which are substantially the same as used for endometriosis. For surgical therapies, we have these therapies, but only site reductive surgery can preserve fertility. Among these therapies, COC is often used as a first-line therapy. COC is very convenient to use, but do you use COC for this woman? I'm sure your answer is no, because she has high risks of thrombosis, smoking, high age, and obesity. As shown here for reference, when BMI increases from the range of 20 to 25 here to 25 to 30, and that of 30 to 35, the risk of thrombosis increases roughly twice and 3 times. So in addition to these risks, adenomyosis itself is a risk of venous thromboembolism. So this slide shows change of coagulation and fibrinolysis markers during menstruation in women with adenomyosis. Coagulation markers, TAT, SF, and DD increased, which suggests that women with adenomyosis is in a hypercoagulation status. Actually, we experienced this case, adenomyosis with venous thromboembolism during COC administration. In this case, the large uterus, which compressed pelvic veins, further enhanced the risk of VTE. The next option is Genogest, which is free from the adverse effect of COC, thromboembolism. In my country, Genogest is the only progestin approved for adenomyosis. As you know, Genogest is shown to be equally effective as leuprorelin in the treatment of endometriosis. So then, how about for adenomyosis? So we demonstrated some time ago, Genogest suppresses pain symptoms here in patients with adenomyosis. We've also shown that long-term treatment of adenomyosis with Genogest, 1 year here and 5 years in average here, was successful. So in using Genogest for adenomyosis, we should be aware that a typical bleeding is a common adverse effect. In general, the number of days of bleeding increases up to 8 weeks and gradually decreases afterwards. The bleeding pattern is mostly less than menstrual, as shown here, and becomes less and less over time. Now, I conclude that Genogest is effective and well tolerated in the treatment for painful symptoms associated with adenomyosis, and Genogest is a good option for long-term management. But it entails high incidence of genital bleeding. So what is the risk of heavy bleeding and anemia in Genogest therapy for adenomyosis? I skipped the data today due to time constraint, but we found that these 3 factors were involved: large size of uterus, adenomyosis at whole myometrial layer, adenomyosis in diffuse type. I recommend that Genogest should not be used or used with special care in these cases. And for example, we experienced this case, 45 years, have been treated with Genogest for 9 months and had these 3 factors of high likelihood of heavy bleeding and anemia. And she was using warfarin and aspirin due to the history of pulmonary embolism and thromboembolic pulmonary hypertension. And she made emergency visit after persistent AUB for 2 weeks and ended up with emergency hysterectomy to obtain hemostasis. So next one is very new, Genogest low dose. A traditional use, which is approved so far, is 2 milligrams per day for adenomyosis as well as for endometriosis. Then what about a lower dose, 1 milligram per day? We conducted RCT comparing Genogest 1 milligram per day, and placebo in patients with primary and secondary dysmenorrhea. So here the result. Changes in dysmenorrhea score at 12 weeks from baseline. It's obvious that Genogest significantly suppressed dysmenorrhea, and the result was substantially the same. Even dysmenorrhea was subdivided into primary dysmenorrhea and secondary dysmenorrhea. And in this here, secondary dysmenorrhea comprises dysmenorrhea with endometriosis, adenomyosis, and or fibroids. This is the result of the phase 2 study. And here, 0.5 milligram twice a day, and that means 1 milligram per day, seems a little bit weaker than 1 milligram twice a day, but much better than 0.25 milligram twice a day. So we adopted 0.5 milligram twice a day for phase 3 trial, which I've just shown. So this is also from phase 2 study, the changes of serum estradiol levels. Interestingly, look at here, 1 milligram per day did not decrease, while 2 milligram per day decreased estradiol levels. And the decreased levels were not so low as expected in GnRH analogs, which are not shown here. But the difference between 1 milligram per day and 2 milligram per day is very clear. How about uterine bleeding, a very common adverse effect of Genogest? The number of days and the severity of bleeding were similar between 1 milligram and 2 milligram per day, or rather, 1 milligram per day seems preferable to 2 milligram per day in terms of genital bleeding. So next, GnRH agonist and GnRH antagonist. Here's the summary of GnRH agonist. So these things you are very familiar. And GnRH agonists have problems, which are flare effect and poor controllability due to sustained release drug. So to overcome these problems, oral GnRH antagonist has been developed. So in my country, only relugolix is approved as GnRH antagonist for fibroid as of now. Its usage is once a day by oral administration. So these are papers where we compared relugolix and leuprolide in RCD for fibroids. And leuprolide increased estradiol levels at the beginning, which is known as flare effect, and at 2 weeks. And in contrast, relugolix quickly suppressed estradiol levels from the beginning. So here shows proportions of patients with a total PBAC score less than 10, which means no or very little bleeding. And look at here, relugolix exerts its effect more efficiently than leuprolide at weeks 2 to 6. And the effects are equivalent at weeks 6 to 12. And the uterine volume decreased faster in the relugolix group here compared to leuprolide group. So this is 2 weeks and this is 4 weeks. The pain scores were decreased over time in substantially the same manner between the groups. And in terms of bone density, both relugolix and leuprolide decreased BMD in the same fashion. So continuous use longer than 6 months is discouraged in both drugs. The data I've shown so far is for fibroid, and we do not have the exact data for adenomyosis now, but based on our experience of GnRH agonist on adenomyosis, similar data would be obtained in adenomyosis. So in terms of published data of GnRH antagonist on adenomyosis, I found only one case report by Professor Dones. They found that linzagolix, another oral GnRH antagonist, reduced lesion size and improved quality of life in a patient with severe adenomyosis who was previously non-responsive to treatment with a selective progesterone receptor modulator, ulipristal acetate. And very recently, elagolix, which is another GnRH antagonist with ADVAC treatment for fibroid, was studied. ADVAC here means addition of hormone replacement therapy to relieve the hypoestrogenic effect. And elagolix with ADVAC here was as effective as elagolix monotherapy. Here. So these therapies are equivalent in reducing the symptoms. And as you can see, bone loss was much lower in elagolix ADVAC therapy. So it seems a very good news. However, the size reduction for uterus and fibroid, which were observed in elagolix alone here, were not observed elagolix with ADVAC therapy. So I think presumably similar findings might be obtained in adenomyosis, but there's no data now. LNG-IUS is also used for adenomyosis, but irregular bleeding is a common adverse effect, and expulsion of the device may occur when adenomyosis causes deformity of the intrauterine cavity. So these sequential therapies are developed for endometriosis by Professor Joe Kitawaki to keep the effect of GnRH agonist on endometriosis, or to suppress adverse effect of erratic bleeding in Genogest. So now we have more drugs. Other combinations such as GnRH antagonist and low-dose Genogest could be a choice. So finally, I'd like to sum up my talk by showing suitable types of adenomyosis in using each drug. COC for mild symptoms, no or low risk of thromboembolism. Genogest, low risk of anemia for long-term use. Genogest low dose for small lesion adenomyosis, dysmenorrhea as a main symptom, low risk of anemia, and for long-term use. A GnRH agonist for large size uterus. GnRH antagonist, large size uterus, and amenorrhea needed as soon as possible. So LNG-IUS, small lesion, normal uterine cavity. So GnRH antagonist with ADVAC, nobody knows, further study needed. So thank you for your attention.